Welcome. Thank you for joining us at this TCTAP wrap-up interview covering imaging and physiology. We were just in a very interesting session, and on behalf of my co-moderator, Dr. Akiko Maehara, I'd like to welcome our panelists, Collet, Nils Johnson, and Eveline Regar. So to start off the session, Eveline, I wondered if you could comment, we're seeing increasing data supporting the role of intravascular imaging, and in fact, guidelines now give it a class 1 indication. Do you think that it's realistic to expect 100% usage of intravascular imaging with PCI? And if not, which lesion subsets or patient subsets do you feel, it's absolutely necessary to have imaging?
Well, Bill, of course, I would wish for 100% imaging use, but we have to realize that this will depend on several factors. It's first, how confident and is the operator with using the technique? What is his training? How much is he willing to trust what he's seeing? So that is one point. The other point is availability, set up in the cath lab. How easy is it to use the technology? How well are technicians trained to support the physician? So these are very important boundary conditions that will drive the use of imaging from a practical perspective. From a perspective as an interventional cardiologist, I would say basically there is no lesion that does not benefit from imaging, but the tricky point is that you realize that only if you do imaging. It's hard to tell upfront whether you need imaging or not, but it's fair to say that the more complex the lesion, the more benefit you will have by imaging, because it allows you to understand the characteristics of the plaque, the composition of the plaque, the anatomic relation, for instance, to side branches, and this ends up in making your life as an interventional cardiologist easier. It gives you a more predictable procedure. You can select your devices up front, and it gives you a better result and a better prognosis for the patient in the end. So, should we use it in all lesions? Probably not realistic, but using it as often as possible is for sure a good idea.
Yeah, I think it depends on the who use. Meaning if the interventional cardiologist is relatively young, not much experience, he or she should use almost all, because based on this, she or he can learn what is the impact. But like SJ Park, he's using 40 years for the intravascular imaging. Type A lesion by SJ Park may not be, because that he understands what the IVAS is already in his mind. So that's my additional comment.
And there's been a lot of interest in identifying and prophylactically treating vulnerable plaques. Can you comment on the intravascular diagnostic techniques used for this, and how realistic is it that these are actually applied by interventional cardiologists broadly, meaning like the ability to actually identify a vulnerable plaque by your average interventional cardiologist?
So we have the PREVENT trial performed here in Korea that gives us some very interesting answers, even suggesting that yes, we can identify plaques at risk causing clinical events for the patients. They even suggest us how to treat them, optical medical therapy, and in selected cases, even preventive stenting. However, this is a protocol that requires different measurements in the coronary artery and mastery of these measurements. I mean, doing hemodynamic measurements in the cath lab requires some experience even today in our modern system. The same is true for imaging, but it is really offering very interesting options for all the patients that we see, young patients with strong family history of premature coronary artery disease, living in fear of acute coronary syndrome, of acute cardiac death. I think for, at least today, these subsets of patients, it can be very beneficial to analyze them in depth and take this information to guide therapy. So today, selected patients for sure. Yeah.
Nils, what are your thoughts about the data so far supporting identifying and treating vulnerable plaques, and what kind of studies do we need next to move that field forward?
I often come back down to what we're trying to accomplish through PCI. For many patients who have vulnerable plaques, they have no symptoms. These are often ones that we notice while we're there doing something else. They come in for an ACS, we treat the culprit, and we notice another lesion, and maybe we do some imaging or other assessment of it. So because patients feel pretty good, it's hard to make them feel better, and actually that's also what I think PREVENT taught us, is there was no change in clinical symptoms between a strategy of doing PCI in those vessels and not. I've been chastened by your FAME3 results that we probably can't make people live longer either these days with PCI. Medical therapy is really effective, and so I think all-cause survival is probably also not a realistic target. So then it really comes down to one thing, and those are heart attacks. You're right, some patients who have plaque are going to show up unexpectedly one day with an acute coronary syndrome. And perhaps that's something that we could avoid by doing upfront stenting in them. What I found realistically sobering from PREVENT is the fact that they were not able to reduce the number of heart attacks. And that was in a fairly large study that was followed for quite a length of time. And so what that has made me is a little bit skeptical, perhaps. And if I were to then think about what another study would be that would need to sway me, not that I'm the most important one, but it would need to show that upfront PCI reduced the number of heart attacks compared to medical therapy. And perhaps some of the other technologies that are coming along will allow us to do it. Maybe refined upfront imaging will let us get there. But I think at the moment, PREVENT was a little bit sobering that we can't stop heart attacks yet with stents.
Yeah, yeah. Pivoting a little bit away from the imaging side of things, there's been a move in the physiology world away from spot FFR or IFR, RFR measurements and incorporating more of the pullback, thanks to a lot of work that you and Carlos have done with the pullback pressure gradient. And maybe you can update us on the latest data and your thoughts about PPG and its role in guiding PCI?
Yeah, it's actually a question that it seems unrelated to the previous one you asked, but there's a lot of crosstalk between how plaque is distributed in the vessel and the vulnerability of plaques. But maybe just let me back up and talk about, I think, some of the things that Carlos was motivated by in developing PPG. And that's that when we look at an angiogram, number one, we underestimate the amount of diffuse disease. That's quite clear from a lot of the data. But then also when you start to do pressure pullbacks, it's hard sometimes to get people to agree. I might look at it and say, boy, that right there, that's the spot you need to do. You might look at it and say, that's all diffuse. I would leave this alone. And so the first step, I think, was to try to develop something that's practical, that's quantitative, and then is able to separate out focal from diffuse along a spectrum, because coronary disease is a spectrum. And so a lot of the early work on PPG was trying to develop and validate, I think, a way that you could do this practically. It's not possible to do pullbacks with devices with some kind of traction on the pressure wire. That's just never going to work day to day. So can you pull the pressure wire back in a way that's repeatable among operators, that nevertheless gives you useful information? And what exactly should the calculation be then to try to say that's focal and this is diffuse? So I think that was a lot of the early work on PPG. Once you have that as a tool, the next question is then what can you learn from applying it? And so the next really wave was in trying to do several studies which are largely observational registries, taking a look at making these PPG measurements, letting operators do what they kind of normally do, and then trying to understand how it impacted clinical endpoints. And I would say that probably one of the most powerful messages that comes out of it is that when you're really trying to match a focal therapy like PCI you want to have focal coronary disease. Doesn't it make sense to apply a focal treatment with a balloon or stent if the plaque is just everywhere along the vessel? And that's largely what has come out of the studies, is that patients who have focal disease respond much better in terms of being able to not only increase the FFR value by the end of the case, but also then make patients feel better over time. So angina relief is much more dramatic in patients who have focal coronary disease. It certainly made me very skeptical about treating diffuse disease with stents. The rates of peri-procedural myocardial infarctions are higher. You close more side branches when you sit there doing very long stents in diffusely diseased vessels. And I think one of the other pieces that's come out of it is this crosstalk between plaque vulnerability and how the pressure gradient is distributed along the vessel. It might not be an obvious thing at the beginning of that journey to say that there is a relationship between the two, but that's clearly what's come out of a large number of cross-sectional imaging studies and plaque distribution studies, is that the focal lesions are the vulnerable lesions, and the diffuse disease, on average, has fewer plaque vulnerable features, really suggesting that when we treat focal disease, it just by whatever the mechanism is that leads us there, we manage to do two good things at once. We can make patients feel better, and we're also treating vulnerable plaques at the same time.
Carlos, we were just in an interesting session on coronary CTA, and there's been a lot of discussion about the new photon counting CTs, about new algorithms for applying physiology as well as plaque analysis, and I think coronary CTA has really moved in front as a gatekeeper to the cath lab. I know you've been doing a lot of work in this idea of PCI planning, based on coronary CTA. Can you comment a little bit on how you incorporate this in clinical practice and your experience so far?
Yeah, so what we're seeing in the field is that a few years ago, the guidelines both in Europe and in the US recommended CT as a first-line test for patients with chest pain. And that basically resulted that the majority of patients referred to the lab today will have a CT performed just in the context of the diagnostic workup. So we try to use that information and say, what can we extract from the CT that could be relevant for the PCI procedure? And no surprise, we found that it's extremely useful. So basically, you can prepare yourself for what you're about to do in terms of selection of access, guiding catheter to have optimal support, understand the necessity of plaque modification using advanced calcium modification tools, and even select the stenting and have a clear map of the PCI procedure. So in that context, we launched a large randomized clinical trial, the P4 study. We're finishing recruitment in the next month, where we're testing whether this approach that we call CT-guided PCI, which is a combination of planning the procedure before you go in the lab and also having an online guidance with the plaque in the three vessels available during the case, actually results in the same outcomes as an IVUS-guided PCI, which we believe is the best way that we have today to do PCI procedures. Eveline, this is an all type of commerce, not only complex, so I think we're going to see that incorporated as well in the study. And we're pretty excited because we are seeing how that already changed the practice of almost all the sites participating in the trial. So when you have these early signals that the investigators are really encouraged and excited about performing this type of PCI plan with CT, you see how that will actually become part of the standard of care that we're aiming at.
Has your practice changed such that, there's some patients who we meet, whether it's chronic coronary syndromes where they have classic symptoms and a non-invasive test isn't really going to change whether or not we go to the cath lab. Are you doing a coronary CTA in these patients just so that you have that data already? Or maybe like, say, ACS patients where you're going to go to the cath lab? Or is this reserved for people where you're also using it to decide about whether to go to the cath lab?
Well, that's a very good question. And I will tell you, that question has actually an evolution in the answer. And I have to say that at the beginning we said, okay, listen, there are 60-70% of patients with CT, let's use that. What we have seen is that operators sometimes do a diagnostic angio. They're familiar with the benefits of using CT for PCI planning. Sometimes they stop the procedure. They say to the patient, you go to get a CT, and then they bring them back with a lot of information. That's not what we're doing in the trial, but I have to say that for certain lesions, this makes a lot of sense. For osteal lesions, having the right angulation is crucial to know where you're landing with the stent. Bifurcations with calcification, when you can know exactly the position of the calcium relative to the side branch, that change the PCI technique that you're going to apply. So what we're seeing is early data. These are all pioneers trying to understand how this helped them. And I do believe that even not only for stable, but it's going to go also to perhaps the non-STEMIs type of patient that you have a few minutes, a few hours, I would say. And the reason is that at the beginning, we needed like 4 or 6 hours for every case to prepare all the materials, to do the reconstructions. And what I have seen now with AI is that what we did before in 4 or 6 hours is basically now 2 or 3 minutes. And that will just facilitate the interpretation of the CT for the interventional cardiologist. And no surprise, the industry is coming with a number of software that have been designed for the interventional cardiology. So you will not be again faced with these platforms for radiologists with 300 buttons. Now it's going to be very simple, cath lab integrated, 2 or 3 buttons, only the important information, where that I think will be extremely useful for guiding PCI.
Yeah, great. Actually, Akiko, I wanted to pivot back to imaging and ask you your thoughts, because this is a question that's bothered me for a long time, is, you know, the cases where you cannot achieve an optimal result with intravascular imaging. Or maybe we should say, you know, we look at studies, they often dichotomize, well, if you got an optimal result with intravascular imaging, you had a very low event rate, but if you didn't get one, and it implies that the operator just didn't pay attention to the result and didn't try to optimize it. But I wonder if that's, I mean, maybe that is the case in some cases, but I wonder if it's more that these are certain types of lesions that you just can't get an optimal result, and therefore they're higher risk and they have higher event rates. How do you look at that issue?
Yeah, I think I changed my mind a lot by looking at those type of the data. It's very consistent. Renovate PCI, Illuminium 4, or any other study, when we look into the imaging guidance, the optimal criteria met only 50% all the time. Who do, what type of modality is always same. And I do think that's most likely lesion, because same operator is doing. I don't think one time he is ready, on the other time is not. I think it's more likely lesion specific. So I think go back to the CT. So if we expect at the end we have the under expansion by CT recognition, I think maybe we have to consider not treat by PCI. Or we may not improve the patient symptom. If so, don't touch, no treat, or just doing the balancioplasty. That's my interpretation. So I don't think that's more likely operative issue. It's more likely lesion specific. Yeah.
Great.
Okay, so I think we didn't talk too much. We didn't talk anything about the QFR, what those things. Okay, I asked the Fearon. So what is the update? What do you think? Where we are?
Yeah, so there was the recent Favor 3 Europe, getting my acronyms mixed up, that looked at QFR guided versus angio guided, and unfortunately did not show a benefit, or versus FFR guided, and did not show wire-based benefit. And so that put a little dampening on people's enthusiasm for angiography-derived physiology. But I think the jury's still out. I think that not all techniques are the same. We've been doing a study called All Rise that randomized 2,000 patients to a different system, FFR angio technique versus wire-based physiology, either FFR or non-hyperemic pressure ratio. Enrollment was completed in January, and it's a 1-year follow-up. So hopefully around a year from now, we'll have the results from that and see where things stand then.
Yeah,
Sounds good.
Bill, I think it's fair to say, to add to your comment, that while the Favor Europe trial show, I would say non-inferiority, to say it correctly, compared to wire, the Favor China trial shows superiority against angiography alone. So I think that there is still a benefit. If you are not using physiology at all, these tools will be of benefit, because you will be deciding, at least based on a simulation, that is better than angiography alone. And the message that I got from Favor Europe is that, well, if you have the possibility to use the wire and you like to use the wire. It's going to be better than the other. But I think there is a scale of benefit, and certainly using physiology anyway improve compared to angio alone.
Yeah, agreed.
Okay, so to summarize, I do think we are in the stage with very matured PCI era. Do you agree? Imaging is class 1A, and physiology we use many different ways, but we confirm the final optimal PCI was well done by physiology based as well. So that's how we are. And we know PCI doesn't change patient all-cause mortality. We are changing patient symptoms. So we really have to ask, what are we improving by doing this? So altogether, I think we are good phase to move the CT is a very good timing. So I think we are looking for the future, more matured PCI. That's how we are.
Great. Well, thank you everyone for joining us at this 30th anniversary of TCT AP 25, and hope to see you in the conference.